to say what's the structure, and then we'll introduce ourselves, and then we can start discussion. So we want very much this session to be interactive with you, and particularly to our main presenters, so they can have very valuable feedback and insightful questions. So first of all, maybe we will start introducing ourselves. So maybe Jen, what do you want to do? Sure.
Hi everybody, it's an honor to be here and interact with you all. I'm Jen Edelman. I'm a professor at the Yale School of Medicine.
Thank you, Jen. So my name is Claudia Lopes. So I'm research lead at International Institute for Global Health here in Kuala Lumpur.
Hi all, I'm Lin Hui. I'm one of the second-year Miss Scholar, currently studying at University of Malaya.
Hi everyone, my name is Mona Sheikh Mahmood. I'm also like Lin Hui, a PhD candidate at University of Malaya, and I was the first batch of MIST scholars. So here I am again, 3 years after, right?
You're the COVID batch.
I'm the COVID batch. Thank you.
Okay, so we'll proceed as follows. So Mona is going to present our research, and then we will open the floor to questions. And Jen and I will comment on the methodology and the ethics and human rights implications. And then we will give the floor to Min Hui, and she will also do her presentation, and then we have some discussion afterwards. Okay? So please, you can start, Mona. Thank you.
Thanks, Claudia. Okay, I'm nervous. It's taken me quite a while to get to where I am today, so feel free to ask questions because, you know, I think every PhD journey is different. I shall qualify myself. I'm non-medical. I was the first student in UM to do Masters in Public Health that has no medical background. I was literally the lab rat, but I got through it. And I've been practicing public health work for 20 years now, mostly in NGO work, in community settings. And I've been a consultant for more than 10 years now. And I am currently also working with UNAIDS Technical Support Mechanism as the Regional Technical Advisor to Asia Pacific, and also the Community Focal Point. And I'd be more than happy to discuss that with you as well, because that's real-life implementation of programs globally. So most of the countries that we've used as examples today, you know, they are in my portfolio. I've peer-reviewed their Global Fund proposals, and I can tell you that we've still got a long way to go. And I think this topic today is timely because if we don't address human rights issues, gender, stigma and discrimination, you know, it's just going to be difficult. So perhaps before I start talking about my research project, I thought I'll go backwards and to talk about human rights, concerns, stigma and discrimination, key populations and HIV. This is where we are at the moment. 25 out of 36 countries reported more than 50% of people aged 15 to 49 years old display discriminatory attitudes towards people with HIV. So one of the building blocks in HIV programming is the stigma index. And any country that wants to put in a proposal to the Global Fund, and the Global Fund is spending billions and billions of dollars on HIV, TB, malaria, would require countries to conduct a stigma index study. And this is used as a baseline. And we're still getting this sort of responses. There's still a lot of stigma and discrimination towards people living with HIV, especially people from the key populations category. Punitive laws and absence of enabling laws and policies and inadequate access to justice undermine HIV responses. We know that. We know that people who use drugs, men, transgender people, sex workers, are considered as criminals in our country. We have not quite addressed that issue adequately. At least 92 countries criminalize HIV exposure, non-disclosure, and or transmission, including Malaysia. 48 countries or territories continue to block people living with HIV from entry, stay, or residence. This is a real problem for example, students coming to Malaysia to study, or people, or migrant workers coming to Malaysia to work. They all have to go through HIV testing. And then when they are tested positive, they're denied entry. And if they're tested positive while they're in Malaysia, meaning the exposure is in Malaysia, they get sent back. I am still very, very disturbed about this, and I think we need to rethink our policies because HIV is no longer a death sentence. Treatment works really well. Among countries reporting data to UNAIDS in 2019, 32 criminalizes and or prosecute transgender persons, 69 criminalize same-sex sexual activity, and the last point here is 129 criminalize some aspect of sex work, and 111 criminalize the use of or possession of drugs for personal use. So we have these ambitious targets. Professor Berman touched on that a little bit this morning about the 2025 HIV targets. Now we've gone up from 90, 90, 90 to 95, 95, 95, but I'd like to bring your attention to the 10% on the left, where we are targeting, and this is the commitments made by most countries globally for HIV targets, that there will be less than 10% of people living with HIV experiencing stigma and discrimination. Okay, so now let's go back to my study. So I'm conducting my study in Indonesia. Indonesia's got a significant HIV epidemic and is considered as a high priority country with high impact, and therefore there's a lot of foreign funding going to Indonesia, and this is because they have not been able to quite reach their 90, 90, 90, let alone 95, 95, 95 target. So in 2022, there was an estimated 526,000 people living with HIV. We're looking at close to 30,000 new infections last year, and 25,000 people dying of HIV in 2021. If you look at the treatment cascade, it's really quite depressing, because despite fairly high first 90 target, which is 81% of people living with HIV, estimated people living with HIV, knowing their status, only 42% are on ART, and 19% are virally suppressed. So they've got a long, long way to go. And at the same time, they've got a raging TB epidemic as well. So there's comorbidities there. So we were actually given 5 minutes, so we didn't prepare very long slides. So I'm going to have to go through this very quickly. So the objective of my study is to evaluate the effectiveness of community-based participatory approach, CPPA, as a strategy in facilitating the adoption and fidelity of a stigma intervention that was conducted in, I can't remember exactly total, because we're looking at both public and private healthcare facilities, but for the purpose of my study, I am only looking at 42 puskesmas, which is equivalent to our klinik kesihatan. Puskesmas is Pusat Kesihatan Masyarakat, and they call it intervensi penghapusan stigma dan diskriminasi. So it's IPSD for short. And basically, I'm doing a mixed method study, both qualitative and quantitative. So the qualitative is really to look at the contextual factors to identify barriers and facilitators of using CBPA as a strategy for the implementation of IPSD. And then for the quantitative study, we're looking at factors. And this is where that whole implementation science framework comes in. Because I've used CIFIR, which is the Consolidated Framework for Implementation Research, to frame my study questions, my questionnaire. So I've taken the long route, and it was a very long route of developing and validating my survey instrument. That was painful because it is a long process, but it was worth it because I learned so much from that process, and I was able to also engage with the communities in Indonesia in the process of developing and validating the study instrument, and also experts in the field. But it took a little bit longer because, you know, validation processes is tricky. It has to be rigorous and scientific. And then there's also that cross-validation process where, you know, you translate to Indonesian, back translate to English. So yes, it took a while. So that's finally done. And now I am in the process of collecting quantitative data, so we're about 30% done now. And as for qualitative, I think we've only got a couple more interviews to go. This is the progress to date. So we have interviewed, and with both IDIs, I mean in-depth interviews and also focus group discussions. As you can see, the axis of diversity, that's where we identify the categories of respondents. So we've got policymakers, the international partner and funders, key population peer educators, healthcare providers, well, you can ask me more questions about why I picked those categories of respondents later in the methodology. And then for the quantitative study, as mentioned, there were about 1,100 healthcare workers who were trained with IPSD intervention, and out of 42 puskesmas or klinik kesehatan. And because, you know, people move, as in Malaysia, the head of clinic moves to a different district, different state, different province. So Prof. Rawza, who's my supervisor, said, Mona, let's just do universal sampling and just try to get as many people as possible to respond to the survey, and that's where I am now. So in terms of who we're collecting data from, is physicians, nurses, midwives, and lab assistants, because when they conducted the IPSD training, they actually trained everyone who works in the clinic center, including the satpam, which is the security workers, to make sure that everybody understands gender, sexuality, sexual diversity, stigma and discrimination, and how that impacts on specific key populations in Indonesia, people who are coming to access services in their clinic center. So, just to let you know, there's also a lot of money that's gone into trying to break down the barriers created by stigma, discrimination, human rights violations, gender inequalities. Just from the perspective of the Global Fund, $218 million have gone towards breaking down barriers. And this money goes to community-led response, community-led monitoring, advocacy, and community system strengthening. Basically, it has been proven that we need the community's involvement in order to get good outcomes from our interventions. And yet, as I review Global Fund proposals, I still see a lot of, they forget community involvement. In fact, last week, I was reviewing a proposal that was worth $100 million, and there was no mention of men who have sex with men and transgender, completely, not even in their national strategic plan. It's crazy, but that's the reality that we live in. There are countries that say, no, we're just not going to deal with this. So, good luck to them. I'm not sure whether they will, they'll be able to submit, but so removing human rights related barriers is imperative to achieving the goals that we want to meet. So I guess my question to you is, how can we leverage on implementation science research to promote community participation, to promote community involvement even in our own research in the implementation of HIV interventions? Thank you. Oh, and also I would like to thank my team in Indonesia. I have one girl who was, she is a recovering drug user. She's in my team, and she's been great at providing support in interviewing healthcare workers, because our group are mainly healthcare workers, and they actually responded really well to her as well. So thank you.
Thank you, Mona. Maybe we'll open questions to the participants. And the questions can be related to your research, or if you want to answer some of the questions that Mona asked you. So maybe you'll have like 5-10 minutes to questions and answers. And please don't be shy. This is an interactive session.
Yes.
Yes.
Hello and good evening, my name is Momani. I'm from International Medical University, IMU, and also International Federation of Medical Student Association. First of all, I would like to congratulate you for having such good proposals and project. So, with my organization, we are planning to do such project, but our main focus group is university students. Because we do seek the importance of giving such HIV service and prevention to university students, and there's a lacking of intervention. I have one question that triggered me, because I do look into the same of project implementation between my project and your project. The first question would be, how do you maintain the sustainability of this particular intervention to the community after you already done the studies, and how this can affect the long-term outcomes for the community in Indonesia especially. Second question is how you intervene the CVPA with the community, with the key populations such as MSM, HIV, and how they can contribute into the CVPA in order for people to acknowledge them and also kill the stigmatization towards them. Thank you so much.
Thank you. Great questions, actually. The good news is this intervention is not new. It is actually adapted from an existing intervention. FHI is called Health for All, and it is actually a module specifically formulated for healthcare providers. So what they've done in Indonesia is that they've adapted the module to suit the Indonesian context. In fact, Prof. Raza is also piloting, I think, the Health for All module for the Malaysian context, so you should have a chat with her. But what I think they've done differently in Indonesia is that they recruited people from key population organizations right from the beginning to assess whether or not the intervention is going to be suitable for Indonesia, and then they adapted the module together with key populations and added modules which are specific to, let's say, people who use drugs, MSM, TG, so that there's input from the community. And the community also implemented the intervention with healthcare providers. So in every training team, there were doctors, physicians who are trained in IPSD, and there will be facilitators from key populations. So we had sex workers, transgenders, MSM, people who use drugs, who were part of the training team. Your question on sustainability is a question that I have. Initially, when I designed this evaluation research, sustainability was my third outcome. But then I took it up because I thought berani, to be honest. Based on the feedback that I've gotten today, not all of the puskesmas are actually implementing IPSD with fidelity. And therefore, in fact, when we chose the clinic kesehatan,
We got input from the communities and said, basically we engaged with about 3 different PLHIV networks in Indonesia and said, so which ones of these 42 clinic kesehatan would you rate as good? Okay, and which ones are not so good? So that's kind of our control, right? And I guess I would have to look at the data to see whether or not it corresponds with what the community thinks in terms of performance. And what I would like to get out of this is to prove that, look, when there is fidelity and adoption of the intervention, you will get good outcomes. Because this is a long-term advocacy. If I look at the current Global Fund proposal from Indonesia, it doesn't mention IBSD. So initially it was piloted, paid for by the US government, and then when funding goes, MOH has officially adopted IBSD, but are they actually putting in the funds to continue the training? That's not clear. So maybe next round, sustainability and maybe even health outcomes. I'm also waiting for the result of the new stigma index. So they did one in 2020, and from the 2020 figures, it looks like it's working because the PLHIVs were reporting very, very little stigma discrimination coming from healthcare workers. So let's see in 2023 whether that has changed.
That's triangulation. Yes.
I can probably speak loud enough. Oh, thank you. So first of all, thank you. This stigma reduction is a really important sort of element, and it's sort of a secondary way to sort of really address the gap in this. One of the things I think from a sort of a nuts and bolts, I'm a measurement guy. I like numbers and I like to know something about it. So you've got this evidence-based practice, which I think IPSD, that's the evidence-based, that's the stigma reduction intervention. And when I think about fidelity of evidence-based interventions, and that's going to be your outcome that's really of interest. It's usually X number of sessions, it's whether they completed and stuff like that. How are you going to really measure the fidelity to the intervention? And that's an important piece, and especially because the measurement bias can be a big outcome. And fidelity is not a survey. Fidelity is, if it's 12 sessions, how many of them did it? In the original intervention, they probably had some fidelity measures. They might even have had a fidelity checklist. So I'm looking to see what is it that you're going to be sort of looking at so that you've got that sort of outcome that's there. And then as you're thinking about the fidelity of sort of the delivery of the intervention, whether it's 12 sessions, it's 45 minutes each, it's face-to-face, whatever all of the sort of criteria is for the evidence-based intervention, how will you address the issue? Because one of the things I heard you say was that there's a lot of turnover of staff. So you've got these community-based folks who are doing this, sort of stigma reduction intervention for certain key populations. But then, if you want to have an outcome that might measure, do we know what the turnover is? And then the other sort of thing that I'm interested to see if you have any thoughts about it is when you have the community-based folks who are working with the clinic-based folks, is there a match between the facilitators or the coaches? These are really coaches who are doing the training. And is there a match between the way that the clinicians see them as the people who are doing the education and training and stuff like that? So that's just something that's in bolts. I was really interested in hearing how you're going to measure and what will it mean whenever you've got like lots of staff turnover.
I know, it's difficult, Rick. Thank you for those 2 questions. The first one, measuring. When I designed the survey instrument, I'm looking at 3 domains: inner setting, outer setting, and process. And within the process, in terms of execution, I'm looking, the questions are related specifically to the content of the modules that they have been trained in. So I'm not really looking at numbers of training, but looking at their understanding of the modules that they have in IPSD. So that's missing. Thank you. Not sure if I can turn back now, but certainly something that we can still address in our qualitative study. But through the interviews because we are interviewing heads of klinik kesihatan and also focus group discussions with clinicians and nurses. We are exploring those questions about fidelity in terms of the acceptance and whether, and it's still within the CFIR framework, and whether the clinic itself has provided a safe space for the healthcare workers to raise their concerns, for example, because there are cultural and religious barriers. We acknowledge that in Indonesia, where they may not like the content of IPSD. So during the qualitative data collection, we are exploring those factors. But for quantitative, not quite those measurements. It's really more of straightforward questions like, does this intervention, is it suitable to our organizational culture, our existing organizational structure, or does it disrupt current workflow? So it's more process-driven, yeah.
But I think that some of those latter constructs are more towards the adoption outcome, and what I'm interested in is the fidelity. How are you actually measuring that the intervention was delivered as intended? That's the big question I have, since that's one of the first, the primary outcomes. So how are you measuring that? This evidence-based practice, I don't know the details about whether it's 5 sessions, 1 session, any of these things, but how are they delivering that in a way as it was intended? Because if you do a bad job, it's kind of like you walk into a place and hand washing is an evidence-based practice, and you tell everybody to do that. That's very different than having people on the floor who are reminding people, oh, by the way, did you see that this thing's here? So I'm just trying to get at what is the measurement. Because that's a primary outcome, and it has to be something that you quantitate. Otherwise, it's no fidelity. That's what I'm trying to understand.
Okay.
Any ideas about that?
It's a tricky one. Can I get back to you? Let me just go through my questions again. Because, like I said, when I formulated those questions, it was very specific to the CFIR domains and subdomains. I think it was more focused towards content and adopt. Like I said, it's more adoption. And executing was looking at to what extent the community-based participatory approach affected, their uptake of the content in the modules. So not, like I said, not so much on the training itself, but I guess knowledge increase and awareness, and whether they're actually practicing that in the provision of services after, the intervention.
I'm just thinking that maybe fidelity isn't the outcome that you're looking for. I mean, I heard a lot of the adoption things and how the intervention plays out and whether they feel it's too complex or something like that, and that they don't choose to adopt it that way. But fidelity is the actual intervention. I'll give you an example that might help you sort of think about what it is that's there. So, yeah, thanks. So, let's just say we've proposed this stigma reduction is either education or contact. Those are the two major sort of ways this is education. And so if the education required, I'll give you an example, 3 sessions, each of them is 1 hour, and you've got 5 different subunits that you're supposed to do. those are the elements of the fidelity. Did they do them? Did they do them completely? Did they deliver the content as intended? And so those are things that you can come up with scores, or you can do a checkoff list and stuff like that. So I'm just wondering, have you thought about any of those fidelity measures? Because you've got these community-based folks who are, you know, they're really committed, it sounds like, to doing this, but are they doing it as intended? Because if the delivery isn't full, you may not actually get the downstream effects, like it reduces stigma in the clinic, or the administrators, you know, have got some metric around, you know, stigma reduction. So I'm just wondering if you thought about that in terms of what you're going to measure, and that's it.
To be honest, no, I haven't, and thank you. I guess our safeguard of ensuring that the intervention was delivered according to plan is in our selection criteria. So, for example, in my survey, after the first couple of questions is have you actually attended IPSD training? And from my understanding of the IPSD training is that everyone went through exactly the same intervention, complete, all modules completed. And if they say no, then they can't go on to the next. So, I mean, like, we've collected more than 150 responses so far, and only 90 is valid. So, it's not answering your question exactly, but the assumption is that everyone has gone through IPSD as per how the intervention was designed. But what happens after, it's not addressed in the study.
So I just have a quick comment. First off, just echoing prior comments, congratulations on all that you've achieved and accomplished, and really exciting to hear about this. Just piggybacking on this conversation around fidelity, one comment or one thought around that is there opportunity to survey recipients of services, the patients or clients in these organizations, to ask about what their experience was going to these clinics where training has presumably been delivered, to see what their experiences are. So, you know, in the clinical trials and intervention studies, we're often thinking about, like, as Rick was saying, how many sessions are part of the intervention package, how many of those got completed, what was the duration of them, and then sometimes there's people listening to the recordings of the sessions and seeing, like, how well was the intervention delivered relative to what was expected, and there's like a clear checklist. In this setting, it may not be feasible to do that because of the design and resources that are required to do that. But one thing that you could potentially do is there, if there's opportunity to collect data from, again, participants who are receiving services at these different sites, to ask about what their experiences were like, you know, with regards to the stigma reduction, or, you know, where they may have benefited from stigma reduction impact. I don't know if that makes sense.
Okay. Yes, so I think we had already a methodological discussion. I don't know if there's other questions, but maybe now we will pass the floor to Minho. And we also want to discuss the ethical considerations, but maybe we'll do it at the end, so to make sure that we have a fair distribution of time. Thank you.
Okay, hi all. So I'll straight away go into introducing my research. So basically my project is entitled Laying the Groundwork for the Implementation of Injectable Long-Acting Pre-Exposure Prophylaxis among Key Populations in Malaysia. It has been more than a decade since our oral PrEP was introduced, which is the current regime use TDF, the tenofovir efavirenz. Okay, but so far, what is a concern? Adherence, because the efficacy of our PrEP is actually tied to the adherence. So besides improving the uptake, adherence and also persistence are other key components that we need to tackle. And studies have shown that poor adherence with daily dosing regime has been a concern. So that's why we need to improve our adherence to ensure optimal virus suppression and also prevention. So with this, we actually have a new antiretroviral therapy called cabotegravir, or in short we call it CAP-LA. So this CAP-LA can actually offer a promising alternative to current regimes in revolutioning HIV care. This is because it has the potential to address the concerns with oral bioavailability, pill fatigue, and also the stringent daily adherence requirement. So there were actually variable preferences regarding LA injectable PrEP across different regions and also populations. So it actually highlights the need for us to access the local context. So this project actually aimed to initiate and also document the assessments of acceptability, preferences, and also concerns on the use of LA injectable PrEP among relevant stakeholders, thus laying the groundwork to implement the CAP-LA once it's available in our country in the future. So this is the framework used. It's the same framework as Mona has used. It's called the Consolidated Framework for Implementation Research, SAFIR. So in this case, our innovation is actually the long-acting injectable PrEP in the CAP-LA. And then in phase 1, we actually conduct a qualitative study to explore the perceptions on long-acting injectable PrEP among the key populations in Malaysia. We're actually involving 4 different key populations: men who have sex with men, transgender people, people who inject drugs, and also our sex workers. This is because we want to get different views from the stakeholders. Next, we are doing an online quantitative survey to actually assess the awareness and also the acceptability of PrEP among the key populations in Malaysia. So this one we are targeting about 400 populations, and then we plan to disseminate the survey through both social networking apps such as Grindr and also our NGOs. So in this case, we are involving our communities also, and also we are trying to targeting place that most easy to access our key populations. So after doing these 2 phases, we're actually doing the phase 3, which is to develop a resource guide for training the trainers program. And we will pilot test with stakeholders where we'll involve members of our key populations and also our HIV or AIDS community workers. So as I've said, so this research is actually to lay the groundwork for implementations of CAP-LA. So which is why it basically involves the first few steps of our implementation process. And after that, after we have done this research, so later on, it will be easier for us to implement our CAP-LA and effectively when it's available. So for this session, I think we are focusing on ethical issues, and as Mona has mentioned, ethical concerns is a very big concern in HIV studies. And for my studies, because it involves a long-acting injectable PrEP, so I'll discuss a few ethical issues regarding long-acting injectable PrEP, where people might have concerns like, yeah, now we already have oral PrEP, then why do we need long-acting injectable PrEP? Is it needed? Is it necessary? Yeah, these are some concerns. And also, because currently the data on the long-acting injectable PrEP were mainly from highly controlled settings, so basically from RCTs, so real-world data are still lacking. So there are some concerns regarding like potential integrase inhibitor resistance and also the delays in detection of HIV infection. So these are some questions that we can discuss further later, and also regarding the privacy and confidentiality issue. So privacy and confidentiality is one thing we highlight in doing research with key populations. So with long-acting injectable PrEP, will it actually improve in terms of this, or will it actually worsen it? So there are, I'll just give a few examples. So positively, we can see if we have long-acting injectable PrEP, it might improve access to our key populations because it actually provides another options. So, as I've said like previously, per adherence is actually a problem. So if you have more options, those that don't want to commit to the daily dosing regimens, they can actually have the options to inject the long-acting injectable PrEP. So in this case, it can actually have some positive effects. But negatively, you will need to go to the clinics regularly for your injection because as far as I know, self-administration is still not available. So so far all the key populations will have to go to the clinic, and this might increase some problems where people might ask like, why are you going to clinics regularly? So that might raise some concerns also. And in terms of human rights concerns, stigmatization. So this one Mona also mentioned. So since we're involving MSM, PW, UD, transgender individuals, and also sex workers, so it's still considered like criminals in our country where, so participation in HIV prevention research may actually increase the risk of them being identified as at risk for HIV. So they might have this concern, so they might have these worries, should I or should I not participate? How can we reduce the stigmatization in terms of this? I'll say, in terms of this, involving the community, especially our community-based non-governmental organizations, will be one of the ways because they have access to all our key populations, and then our key populations also have more trust on them. Yeah, this is one way to actually address the medical mistrust. So this is the end of my presentation. Thank you.
So we can open the questions to the floor.
Thank you so much. Again, my name is Mamani. I'm from IMU and I'm from MSA. I have one crucial question. When you mentioned about the positive impact of the long-acting injection PrEP is to improve the access to key population, my concern is more into the cost. If implementation happened, then the cost. We noted that even the oral PrEP, some key population need to pay for it, and more majority of the key population, they come from the low-income household, or Malaysian known as B40 group. So how you address this concern of the cost for all key population, for them to access, and also the availability out there to the pharmacies, especially for them to note it and then get it for free. Thank you so much.
Thank you very much for the great question. So cost is really an issue, and to tell you honestly, a recent presentation from WHO President actually mentioned that cost-effectiveness study regarding this long-acting injectable PrEP is actually still lacking. So we actually do not have enough data proving that long-acting injectable PrEP is cost-effective. And also another concern that they have is the price actually ranges a lot across different countries. For example, in South Africa, they have the access to the generic, so it only costs USD $6 per injection, and you actually inject it every 2 months. So the cost isn't that high, but in US itself, it costs $25,000 per year. Yeah, so it very much depends on access to generic and also your local government policies. So, and as you have said also, in our local healthcare system, many of our key populations are B40. So this will actually depend on our government policy, where we're currently rolling out the oral prep to the clinic kesehatan, and this is where they can get the prep for a low price or even RM1, yeah, at the clinic kesehatan. So if we have some change in the policies, so that might be a easier way for them to get access. And one more question is regarding the pharmacists providing PrEP. Yeah. So currently, as we all know, is the main route to access to PrEP is actually to our clinic, to our hospital, but through pharmacists is still not that common yet, and which is why we actually have another project that is done by Miss Yenny. She is actually presenting in another hall where she is trying to implement a pharmacist-led PrEP delivery model. Yeah, so the project is currently ongoing and piloting with a few community pharmacies. So with that, we actually hope that we start with oral PrEP, and once they are okay, we will continue with injectable PrEP. But we need to figure out factors such as who will deliver the injections, because community pharmacies, we don't actually offer the injection service. Yeah, so there are still obstacles, but I think in years we will actually overcome all these obstacles and make PrEP available for all.
Thank you for your presentation. I just want to ask a comment to piggyback on, ask a question to piggyback on that comment. So in part of the work, I'm wondering if you're asking where people prefer to go to receive the long-acting PrEP, if it's available. So not only asking about like how acceptable it is and their concerns around it, but where would they want to receive that care? Can you just speak to that?
Yeah, so thank you for the questions. So basically, as you can see, we're doing mixed method also, both quali and quanti. And we start with quali first, where we actually ask them questions. Where would you prefer to get your long-acting injectable, long-acting injectable PrEP? So depends on the answer, hospital, clinic, or pharmacy. Yeah, open to them to actually mention. And also, because for this research, although it's mainly for CAP-LA, but we actually open to all long-acting, all possibly coming long-acting injectables, and we ask them your frequency of injections, your site of administration, So we ask them all these questions to see what our key populations actually prefer. And from that, we actually do, because quali is involving less participants, and from there we actually do quantitative survey to see what is the quantitative data on this.
Could you go back like a slide or two in terms of your CFIR framework? And so there we go. So I'm just interested, first of all, congratulations on taking this on, because everybody around the world is trying to figure out how to implement long-acting injectables. And I think it's probably fair to say that all of us, whether we're doing the addiction medicine stuff, we have all of this enthusiasm, and it really hasn't borne out the way that we thought it would be, even though there's an efficacy benefit in the HPTN studies. So, one of the things that I sort of see here, maybe you can comment, because we haven't had a lot of discussion around it, is that you're using the CFIR framework for doing this, but I'm just wondering if there was a reason for selection of the CFIR framework here, where you're doing a fair amount of exploration for an evidence-based practice that is not available. In fact, it's just barely out the door, if you will. And then you're sort of doing some exploration, and then you're really sort of preparing the field and stuff like that. Was there a reason why you chose CFIR over, let's say, EPIS, or an evidence-based practice that's not yet available? I mean, there's nuances between them, and I would have to say there's probably 85% overlap over all of these. But was there anything that went into your selection? Luke sort of talked about a way to sort of select the framework that you might, want to use. I'm just wondering, one, how you did that, and then I have some questions around some of the other parts that I think would, might raise some really interesting questions.
Yes, thank you, Perfect, for the question. So selecting CFIR, to be honest, selecting the framework is actually a headache for me. All of us. There are just too many frameworks out there. So I've gone through like literature reviews on how to select framework, and what they taught me is that you must look back to your purpose of your research and also the context of the research. So in this case, I actually want to lay the groundwork to assess all these preferences, constant acceptability stuff, and also to just develop a resource guide first. So I've looked, so why I chose CIFIR is because first, CIFIR is a determinant framework where it can help to actually identify your context because it has the way to identify your needs and also assessing the context. I know APIS do the same. Yeah, APIS has actually.
All of them have a
yes.
piece of it, yeah.
Yeah, APIS, Paris, all do the same. Yeah. So I was actually in between APIS and also CIFIR. Yeah. But I tried both APIS and CIFIR, and the reason I chose CIFIR is because it actually provided the Excel sheet where you can map one by one of your innovation, your innovation evidence and all. And then when I mapped it, and the way of it presenting the implementation process step by step actually sounds, sounds better to me when I'm trying to plan my research. And I try to do it with APIS, but I just kind of not very get through it because it's a wrong process. But I would say it's very similar where it involves outer setting, inner settings, and all. So for me, I actually think both the framework works. Just depends on preference. At least, yeah, that's for me.
Yeah, so one of the reasons I just brought that up and I wanted to use it as a teaching tool is since last year's implementation science, there's actually a website where you can go into and you can plug in a number of different things and it gives you some guidance as to whether, let's say, you want to use CIFIR or APIS. Or what's emerging is that we sometimes will combine some of the different frameworks in order to be able to answer our question because there's certain, so I really wanted to use it more as a sort of a discussion tool for that. And then the other thing that I think is sort of interesting is that, you know, with implementation science, you know, you've got this qualitative study and, you know, you really have this opportunity to look at the inner and the outer setting, if you will, about what's sort of, you know, getting in the way. And one of the things that I struggle with, because sometimes we do evidence-based interventions that have been around for a while, and people have a knowledge basis for that. But sometimes when there's no sort of experience, and you know, when you look at Rogers' diffusion of innovation, you've got these early adopters and these people who go into, they're very different people than these later folks. And so the sorts of things that get in the way early may not be the same things that get in the way later. And so, you know, that's one of the things to sort of happen, and that as people have good experiences, that'll be important. But assessing this, you know, we've got around the key populations, but I would say that there might be some things that get in the way of long-acting PrEP from a provider perspective as well. And, you know, and where there is a match, those are some things that you can tackle, but when they're really, really different, your implementation strategy may be different. I'll give you an example. If the providers tell you, you know, I don't really want to stick a needle in somebody, you know, who might have HIV whenever, you know, down the road because they missed a dose or something like that. So there's some anxiety around that. You know, one of the implementation strategies might be, not available right now, self-injection, right? So these are some of the ways to sort of think about it. And I'm just wondering if you've thought about some of those and how you are going to really sort of attack the various different, either the people on whom the evidence-based practice are going to impact, both as clinicians and as patients.
Yes, thank you, Prof. for pointing out the providers part. I actually hesitated whether I want to put it because I know it's gonna bombard it. No, actually, this is actually, to be honest, at the initial stage, we wanted to include our HRV PrEP providers also because they are one very important stakeholders. But why the current project is like this is because we found out that if you want to include them also, you need a total different resource where you need a total topic guide, you need a total different survey, you need a whole new, you need a lot of things where we couldn't do it within this project. And we actually hope that later on, someone will actually continue or do some projects on the perspective of our prep providers also, and then we can actually see what are the results from our studies and see how we can match it. Yeah.
Well, I mean, you know, another option would be is that you learn, let's say, for instance, from the patients first, and you get some ideas. Let's just say, you know, for example, that people don't want to go to an HIV clinic, as you mentioned before, so they go to a baby clinic in Kasikatan. Or the other issue is that, you know, these touch points where, like, building on Jen's question, maybe they want to go to the syringic services program. Maybe they want to go to an NGO or something like that. But then from that perspective, you still have to go back because the people in the NGO or the pharmacy, you know, I think the pharmacies are, you know, the wave of the future. And so, you know, if you've got like a, you know, passcode for like $200 sort of thing, the pharmacist can then just do that, or the pharmacist can be trained to do some of these things. So you might want to sort of like even have a sequential sort of strategy, because if you find out from a patient perspective that it's just not going to be feasible because the providers won't do it, it would be really good to sort of triangulate that.
Yeah, actually we have collaboration also where our Dr. Susan over there, she's actually interviewing PrEP providers also regarding LA injectable PrEP. So hopefully the results from all these studies we can discuss together and see what's the way to move forward.
Just one comment there. So for phase 3, where you're looking to develop a training package, it seems that having clinician input, it depends on who you're looking to train, right? If you're training potential recipients of the PrEP, right? Or if you're training the providers, you really want to have the provider input. When I read your phase 3 and you talked about it, I was assuming it was for clinicians. But I don't know who's going to be trained in phase 3, and if you can unpack that a little bit, because I think if it's clinicians, it begs the question of really how can you get their input before you hit phase 3.
Yeah. So far the input from the clinicians is mainly still from our experts, because at the first stage we actually form a team, and inside the team we actually have a few HIV experts clinicians, including like Professor Sana, Prof. Adiba, all this. So we are getting the input from the experts besides getting from literature review and also phase 1 and phase 2. But if we have the capacity, then it's better if we can get even more input from other healthcare providers. So hopefully from student study we can actually get that input also and modify our the trainers program accordingly.
One second. Hello. Hi. It's just something I'm curious about. Since you're talking about long-acting, it feels like this kind of medication is for people who are far from the system, who are maybe who cannot really access, doesn't really have frequent access to clinics and so on. So I'm just curious what kind of ways that you maybe use to disseminate to these kind of people who are far from the NGO, far from the systems. I'm just curious about that. Thank you.
Yes, thank you very much for the great question. Yeah, this is another very important thing in terms of improving uptake of PrEP also, where decentralization, demedicalization are all important things to improve the uptake. So as you have said, the LA injectable PrEP, not only it can improve access, also it can address the daily adherence problem. So in terms of improving the access, we are hoping in the future we can actually roll out this to the clinical settings where they can have easier access to the PrEP, and going to the clinical kesehatan 2 monthly compared to taking daily dosing, which they might not adhere to, would actually help to solve the problem. And with taking injections also, we can actually monitor their adherence, because if your patient get get the medical, to get the pill and go back. You never know they actually take it or not. But with injections, you actually monitor them. So it's a very good way to monitor adherence also.
Hi, this is Anne. I'm a research assistant at the University of Malaya Medical Center, UMC. Thank you, Ms. Mona and Min Hui, for sharing your research with us. It's very inspiring. I have a question regarding minimizing stigma. In my opinion, I think first thing first is to address it. However, I feel like in the Malaysian context, addressing stigma is not the easiest thing to do. To be honest, it's a little bit complex, and people, how should I put it? Maybe I should say like it doesn't feel so safe to do so, right? Because like in the American context, the freedom of speech is protected by the First Amendment. However, there's no such thing in Malaysia, like based on what I know. So maybe this question is also for Dr. Claudia, whether or not there is such thing internationally that can protect, like provide this protection for Malaysian people to speak out, and also to talk about this stigma, especially people who work in the field, who are affected, like key population, people from the community, to speak out more, so that, because it's not only like effective, it's also powerful, it's empowering, and I think that, I think that it would be great for us to know if there's something like this to provide the safe space for us. Thank you.
Okay, thank you, and thanks for that question. So maybe this is a very good segue now for the ethics considerations and human rights considerations. So we still have half an hour, so we can take some time discussing it. And so maybe I will clarify what is the role of the United Nations University. So we are not a UN agency as UNHCR and UNICEF and others, so we don't work directly with communities. We are a platform, we are a think tank that we do the connection between the academic knowledge with universities, but also we translate this type of knowledge into policy, so we work with government. So we don't work with communities as much, but we are interested in community engagement. We work on implementation research. So we compile some findings of what works in terms of engaging with communities and disseminate it to others, NGOs and governments who work directly with the communities. So we are one step removed from the communities, but thanks for your comments, that I think is really important for them to feel safe to speak up, to have a platform for voice. And we know that some political conditions, the social norms, they may not be conducive to that. So it's just important, I think, to create these safe spaces, and it could be in the communities, through the NGOs, so they could also have a say in these interventions that is going to change their lives. And I think implementation research, in a way, is one step towards it. Right, so through the research is a research where we can involve the community, so that's why stakeholder engagement is so important. So maybe I will provide I don't want to spend a lot of time with the slides, but just to give you some principles, some guidelines that will be the basis for discussion. Okay. Okay, so this is just an overview of the United Nations University. So we are based in Malaysia, in the International Institute for Global Health, but there are 14 other research institutes in different countries. So we have a global mandate, so we don't work only in Malaysia, we work globally in low and middle income countries. And the objective of the United Nations University, the International Institute of Global Health in Malaysia, is to build knowledge and capacity for decision making by UN agencies, UN programs, and member states, and advance evidence-based policy on key issues related to sustainable development, global public health. So we work mainly in terms, if you want to talk about the SDGs, on SDG 5, that is gender equality, and SDG 3, that is good health and well-being. But we work on SDGs is a system thinking approach. So all the SDGs are interconnected. So we now start working on a program on climate change. We work on digital health. So I think in a way we work across the SDG framework, but with a specificity on the gender and health. So I just had here the objectives of this session. I think that it's like to understand what are the ethical principles to conduct implementation research and strengthen the skills in the implementation of these principles and assume responsibility for and apply them to your daily work. So these slides will be available, and and the learning outcomes has to do with the higher questions and ethical considerations when we have these questions, the responsiveness of the high heart to community needs, the higher design and the ethical considerations of the specific methods and designs that are different for different methods, and the ethical considerations in the community and the stakeholder engagement. So as you all know, I'm assuming that all of you know that, so there are different research ethics framework, that is the biomedical and clinical, the research ethics that applies to, for example, social research, and the public health ethics. So the implementation research ethics just is embedded in some of these principles, but it doesn't overlap completely. So there are some specificities, and I'm not going to go through it, but like in terms of the differences between the biomedical and clinical research and implementation research, you have fundamental differences, such as implementation research, we are working not only with individuals, but with institutions, with communities, with health systems. So when we want to balance the risks and the gains, we don't know beforehand what the risks will be, because it depends on the context. It will unfold during the implementation research process. So in terms of the risk assessment, it will be less informed and less completed than if you have the clinical or biomedical. For example, in terms of the control, we know already that these interventions are efficacious. So we know that by having individuals in control groups, we are denying them the opportunity to have the benefits of the intervention. So we need to think about the ethics in 3 phases. So the planning, the implementation, and the post-research phase. And there are different points for each one of them. So I'm also not going through all of them, but I just select some important ones. And maybe more than making this a lecture, let's also have it a bit more interactive. And now we'll invite Mingwu and Mona to discuss what are these aspects applied to your research. So, for example, the planning phase, we have responsiveness to the local needs and priorities and equipoise. So, and we have others, but I think these are important ones. That is, so how your research is responding to a need that exists in the community. So, have you reflected on the agenda that is driving your research? And for example, we are doing it in different contexts, different countries, but have you thought about the health systems and in the way that your research is embedded in the health system and is prioritizing important needs? What are the scalability and sustainability of your research? And will the intervention reach those who need it? So can you just give me a very brief comment on how you thought about these considerations in the planning phase? You can also talk about equipoise if you want, like is it worth doing when you balance the risks and the gains? Do you think that that will be the way to go? Especially, I think, in your case, like our technology is available, reliable, and affordable. That's a very important ethical question for your research. Okay. Do you want just to talk about this planning phase, the ethics considerations?
Okay. Yeah. Then I'll start first. I think the planning phase is like that I have said. So is this really needed? And I've actually mentioned a few times in my presentation just now. This is also one of the questions that we'll ask. We have our PrEP. Why do we need a long-acting injectable PrEP? Like just now, our participants have mentioned. How about cost? Yeah, cost is always an issue. So I think these few concerns I've actually mentioned, because with our current oral PrEP, there are a lot of our key populations, they are actually still not taking PrEP, given it's due to their different concerns to acceptability and also due to adherence. And long-acting injectable PrEP has the potential to address this. So with the given benefit of this, I think it's inevitable for us to move towards that stage, providing one more options for our key populations. And then also whether it's scalable and sustainable, for this I do not have an answer now. But from some other real-world implementation, especially they have done a few real-world implementation in Uganda, South Africa, all these countries, yeah, it seems like it's working, but we'll probably need the access to generic, as I've said, because the original brand is that might cost a bit too much, especially for our key populations. So that's something we need to ponder in the future. And is it available? Yeah, that's another very important question. So during, I think, a few months ago, there was actually a conference where the United Nations actually mentioned that by 2037 it will be available in Malaysia, and there are actually some news from them that it might be brought forward. Yeah, so in a few years' time, the carboxyl will be available in Malaysia, but we are not known about their costs and others yet. And obligational to do, yeah. So far for the long-term side effects, there are still lack of data on the long-term side effects, but today, regarding the resistance part, which I mentioned just now, within the trials itself, the HPTN 083 and 084, there are actually no integrase inhibitor resistance. So that's not an issue at the moment, but we don't know, we need more long-term data. And but we have some issues regarding the delay in detecting HIV infection. So that's one thing that we need to highlight, where for these patients that are started on carboxyl, we actually need to make sure they come back for HIV testing in 2 months' time, and we will suggest the use of HIV RNA testing. Yeah. So that might be another cost of the HIV RNA testing that we need to factor in also. Yeah. Thank you.
And maybe you can have some general comment. I think maybe for your research it will be more this part of that. Is it scalable? How can we embed your research into the health system and is responding to the need?
Thank you. Before I answer that, Anne, it's Anne, right? I also wanted to address your question with regards to stigma in Malaysia. I was actually involved in the piloting of IPSD in Indonesia, and I was in a room full of tudung-clad physicians and nurses and male MAs who were trained with a group of people from our key populations. And of course, during the first day, it was very obvious how uncomfortable they were, because they may interact with them as patients, but they don't interact with them as teachers and facilitators. And that relationship changed over 3 days, because there were sharing sessions, and they humanize or demystify what it means to be a key population representative. So that worked. And they were very close, and I think they still very much appreciate that intervention till today. I mean, they still remember me being there. That was about 3-4 years ago. And I have to also remind Malaysians, when we first started the needle exchange program, again, there was a lot of stigma around people who inject drugs, and we did it very quietly. There was no media hoo-ha. We started the programs in 3 sites, Johor, Penang, and where was the other place? I can't remember. Kuala Lumpur, of course. And we set up NSCP sites within residential areas. But, look at us now. We've reduced HIV amongst people who inject drugs significantly in 10 years. What happened to PrEP? We announced it, and then there was immediate backlash. Who from? The medical fraternity themselves, So sometimes I really wonder, when we do this sensitive and potentially difficult to talk about interventions, we just have to do it really quietly with a small group of people people, get the community involvement, pilot it, show that it's effective, and then scale up. And I think that's how we've been doing, KP programs for such a long time. So we just need, like I said, to demystify, to really engage and have the community involved, because they are just like you and me, right? They're people, they have needs, they have their challenges. Now, going back to this, whose agenda is driving research? I don't know. You tell me, whose agenda is it? Is it Mona's agenda? Or is it Yale or or government agenda? It's community agenda. I hope, right? Because they want to be more visible, they want to participate, right? As a key actor in HIV intervention, national HIV intervention, global HIV intervention. Prioritization of needs, yes. We still have not, I think we have not really got a great formula when it comes to community participation in HIV programs, not just in Malaysia but elsewhere. I think we are doing pretty well here in Malaysia, to be honest. I mean, we've got NGO representatives here, you guys can speak for yourselves. But we have been engaging with NGOs for more than 20 years now. They've been leading the HIV programs in the country. But when it comes to clinical work, once you get them, again, like that, those linkages from community-based organizations to healthcare provider and then sustaining them in healthcare services, that's where we always lose them. That's where the loss to follow outcomes happens. So the attrition happens at every step of the way, as we have discussed this morning. Potentially scalable and sustainable intervention, yes, definitely. If it works, if we can show that it works, if it's delivering results, if we are retaining patients in systems because they feel comfortable accessing services from public healthcare facilities, yes, it's scalable. Will the intervention reach those who need it? Well, that's the question. Whether do we make governments commit to it? Does it become policy? Does it become part of the training curriculum for all healthcare providers? Yeah, those are the questions we need to ask.
So if you just move forward and then reflect on the ethics and human rights considerations of implementation phase, and then try to anticipate the post-research phase that you're not there yet. Right? So in terms of the implementation phase, so we need to ask questions related to informed consent. And implementation research, as you know, individual consent is not as important, so sometimes we have only the gatekeeper permission, the community leaders, or this dual level that is a combination. And there are justice considerations that related to standard of care. So what are the existing standards and accepted standards, and whether your intervention is improving the quality of these standards of health standards. So we have these care responsibilities while we are doing research. And in terms of the data collection, so there's ethical issues related with the data sharing, dissemination, particularly in HIV implementation research, right? So confidentiality and privacy is really important, and I think we talked already about that. But it's also, I would like just to stress the implementation phase, that the stakeholder engagement is really important. It's the objective of your research, but it should be in whole implementation research objectives. So, so the implementation research takes what we know and turns it into what we do. So we need to ensure that the communities know what to do, and when we leave, they will continue to do it. So there should be an ongoing engagement with all stakeholders throughout the process to optimize the chance of success and then the scalability. So these are just some principles for the stakeholder engagement. Should be a democratic process, power sharing. Researchers are seen as partners, not dominant. It's important to identify the full range of stakeholders and what are the ones that are less voice, less visibility, and we'll see the implementation research as a platform that they will have to voice their concerns. So what are the channels of accountability, and does the stakeholders, they feel empowered, respected? Does the engagement, who decides the types of engagement and the rules of engagement? Is it a hierarchical, everyone will have also a say of how they are feel more comfortable engaging with others? So all these questions are ethical questions that we need to ask ourselves. And then I just have here risk assessment, that how can we mitigate the harms and minimize them throughout the research, whether it's the individual harms, the social harms, the stigmatization, or groups of subjects involved. That is also, I think, of crucial importance in your research, because you can contribute to stigmatize more individuals if they, for example, if they want to be private, but because of the nature of the research, you need to collect data on them, you need to, and they may not feel comfortable, even if they give informed consent at the beginning, may decide to withdraw at any moment, right? And there's the financial harms in terms of giving incentives or vouchers that may destabilize the local economy, and expectations about other research that I don't think it applies to your research. It doesn't involve incentives to participants, no. It does in your case. Okay, would you like to talk a little bit more about that? I didn't know that. How have you thought about it, and how that will impact maybe future research?
So, in terms of incentives, actually, so far our research will be involving providing incentives to our participants, but it's mainly to actually compensate for their time, because both qualitative and quantitative, it actually takes time. Qualitative interview can easily take up to an hour, and quantitative, the survey can take up to like 40 minutes. So we feel that we actually need to compensate our key populations for taking their time to participate. Of course, I would say that might actually affect the participation rate. Yeah, because with incentives that will definitely encourage participation, but that shouldn't have any effect on the how they respond to our survey and also the interviews. Yeah, so it's more of a compensation. Yeah.
Hi, panelists. So sorry, there's another question here, if you don't mind.
Okay, just talk about compensation, because in development work sometimes I say this is the effect of development work in many countries, because they got used to getting compensated for participation, right? Okay, so there is a small compensation, not monetary compensation. We give them pulsa. Pulsa is apa ya? Telephone credit. Thank you very much. So that's what we give them in exchange for their time for participating in the interview, because it's done online, and also for filling out the survey. So, but we don't actually tell them that they're getting the compensation until they've done it, and then we ask for their account number, and then we compensate. Is that okay?
That's okay.
Just an addition, mine is GrabFood voucher, so it's for food, not monetary.
And there's no definite answer on that. It really depends on the context, right? So, and I think, if you're using the time of the participants, I think they should be rewarded for the time. If you are paying the enumerators, why not paying the participants, right? And yes, so I agree that.
Hi, my name is Henry from University Malaya Medical Center. I'm not sure my question is about the right time, but I would like to deliver asking one question about long-acting PrEP as an example. Because we know long-acting PrEP may require pharmacies to make the suspension and then injection. So do you think that this so-called making a suspension will increase the workload of the current staff? Because we're talking about community lab and also touch shifting. So if you require a specific technician to make the suspension and then subsequently IM and giving the jab, so is it increasing the workload or actually reducing the workload, because the gap may be 2 months ahead? So
That's another question.
So thank you very much for the question. So it's mainly regarding pharmacy. Honestly, I'm a pharmacist myself also. Yeah. So regarding the suspension part, I'll say it might increase slightly of the workload because, as you have said, you need to actually suspend it. But it's a 2 months injection, and also it's a very easy IM injection. Yeah. So it actually doesn't need a lot of work. And what we are targeting later on is not only to deliver it at the hospitals, but also our clinic kesehatans. So hopefully we are providing like trainings to make it just very easy work. And we are also, if we are going to roll out, we are going to ask our pharmacists to get their feedback on how does it affect their work. Because at the current stage, we actually don't know how heavy is the workload. Yeah, but they are one of our stakeholders, and if we roll out, we will definitely ask for their views regarding this. Yeah, thank you.
I just want to go back to the comment around, so I think the theme of the conversation we've been having is around the importance of community engagement, and so just thinking about how that's happening in all steps of the process, and not only reimbursing individuals who participate in an interview, but thinking about how at each stage of the process in our community partners we are including them as members of the team and like as part of the table when you're informing the data collection tools and the protocols and kind of every step, and sometimes even part of the participating in the analyses and thinking about how are we compensating them and reimbursing them for their time. And I just wanted to make a comment. I'm curious to hear how you guys are thinking about that, because I think you were referring specifically to individuals who are giving you their data, but again, investigators are getting compensation for their time, and ensuring that we're compensating our partners is really important.
And that could also include the capacity building on terms of the research skills and digital technical skills. We need to wrap up very soon, but maybe just, yes. No, I just wanted to show what are the considerations for the post-research phase in terms of disseminating research findings back to the communities, back to the stakeholders, and the importance of already strengthen the capacities to conduct, monitor, and evaluate research in the local teams and leave the communities better off, contribute to scalability and sustainability. And just to finalize, I would like to disseminate a course that we have at United Nations University with the WHO. So we piloted last year that was incorporating intersectional gender perspective implementation research. It's an online course book. It's available on the TDR website. And it's exactly how it's like thinking ethically, how can we involve the marginalized groups in the community? We don't talk about gender in itself, it's intersectional gender perspective has to do with gender, how it interacts with other axes of marginalizations, with poverty, with disability, and so on. And what are the strategies to involve communities and involve those who are more marginalized in the communities? So yes, so it's free, so feel free to check the TDR website. The next session is going to be in September this year. Thank you.
I just want to make one quick comment, and that is regarding implementation science frameworks, because it is really important, the theme of today. One framework that I think is important for us all to be thinking about that has come out is the health equity implementation framework, I think is what it's called, which it blends things thinking about health disparities and health equity and the social determinants of health with implementation science, and specifically with the Paris framework. And so that may be something that folks are thinking about. I think it's really relevant for the work that we're doing. So.
We'll talk about the framework also in this book.
Yeah. Okay. Thank you for sharing your amazing work. Thank you for grounding us in ethics, and thanks for the questions. I think we're going to wrap up because we're on to the next.